quite a panel here this morning. We've covered a broad range of topics in liver disease and hepatology, and the size of our panel is limited only by the width of the stage. And so we'll try and give some semblance of organization here, and this is the time we invite members of the audience to come forward with questions. I wanted to start with a question just as we got started, because obviously this is the age of technology and applications, and I think all of us rely on different applications in our practice. So I was going to ask each of you, and I'd ask Claude, he's going to type these up for our audience, maybe not? You okay? Good. I thought I'd just ask you real quickly to give us your favorite app site or website in that you use in your practice in assessing your patients. Francisco? What do you?
I use sometimes up to date and searches with PubMed.
Okay, Bob, you can use your own. You can use your own website.
I want to make a comment about up to date because they just came out with some interesting information about Dynavax, the new hepatitis B vaccine. That there's some safety concerns, and I'm to say up to date is not correct. It's inaccurate. But I do like up to date, and then I do MedCalc, and I also use the hepatitis C website from University of Washington.
Great. Yeah, very good website. And I might add, up to date, I learned at AASLD is that every time that you log on and create a search, you get mock points. You get a half a mock point. That's what I was told at one of the seminars.
Okay, I don't use up to date, but I'm going to start now. I wouldn't call it an app. The only thing that I use is for Hep C is the AASLD IDSA guidelines.
I use Up to Date, and I wrote the Hep C, two of the Hep C pieces down Up to Date, and we get royalties. If you hit it, we get like a 1/10 of a penny. So
keep going like this.
please use Up to Date. Keep hitting it over and over again. And I use HepCalc as my my app on my
Use
phone.
the Tesla app.
Yeah, I'm very thankful for the AASLD's Hep C guide, treatment and guideline page. It seems to change. It's the only website I know that has daily updates for treatment of things, and almost minute to minute. There used to be a button, I don't know if there still is, a button that said refresh, because they could be updating it like while you're looking at it. Slowed down a little bit. I use Google Scholar. I don't know. I think that's actually a very effective search mechanism too.
Alan?
I use the University of Liverpool
Excellent website.
HCV drug-drug interaction site. I also use LiverTox a lot, and I use MedCalc on my phone.
I guess this is the disadvantage of being at the end, because I don't know if I have any novel website to really add, but I use the AASLD IDSA guidelines regularly, and then I use LiverTox. I think anytime I get a consult on possible drug reactions, I tell my fellows that's the first site you should go to.
Great. Well, thank you. I thought that was just a good way. We'll leave this slide up so those of you in the members of the audience may or may not use these various websites. It kind of gives you an idea of what might be useful in day-to-day practice and as you see consults in your everyday practice. So I want to, please come forward because this is really the time for you to ask.
Two things. Number one, vitamin E usage in males and prostate cancer, not really addressed by your speech. The other thing is, with all your non-invasive markers, what's happened with all the bariatric procedures in terms of if weight loss is maybe partially manageable? It'd be very interesting to hear your comments.
Sure. Yeah, so vitamin E, the main risk for vitamin E are all-cause mortality. Risk is higher in one study. Hemorrhagic stroke is higher in another study. And prostate cancer risk done out of San Antonio, actually, with selenium and vitamin E, looking at potential therapies for prostate cancer. Vitamin E actually showed an increased risk prostate cancer. It was totally unexpected. So, you know, it's a large study. It almost hit statistical significance. The p-value was 0.06. So what that tells me is you've got to treat a lot of people with vitamin E to find one prostate cancer. Having said that, I do inform my patients when I add vitamin E that that is a risk and it is out there. How big of a risk? I think it's kind of small, but it's there.
Stephen, wasn't that a synthetic vitamin E? I thought natural vitamin E didn't have that link.
Well, it was synthetic, and the data was in NASH was with naturally occurring RRR alpha tocopherol. However, I'm not sure if there is not a link or it just wasn't studied.
Let's see.
For bariatric surgery, there was a 5-year follow-up study presented at AASLD by Patrick Mathurin. And what he's really the only one that's published data on bariatric surgery to any significant degree. But even in his practice, he combines Roux-en-Y data with sleeve gastrectomy. And then there's also the endo data, right, with balloons and whatnot. So ultimately, what we know is that weight loss of 10%, it doesn't matter how you get there. You know, you zipper up the lips, you put a balloon in, you cut part of the stomach out, or you bypass, you're going to have the same effect on NASH. 85% of people resolve NASH with bariatric surgery. 85%. Now, the problem is you don't do so well with advanced fibrosis. Now, I tried to pin him down with that. I was the moderator for that session. And at the end of the day, there weren't enough cirrhotics that followed up 5 years to actually have data. There were a significant number of F3s, however, and 50% of the F3s actually improved fibrosis, but one worsened with 100 pounds of weight loss. So what I tell people from that is, it's good at resolving NASH, but if you have advanced liver disease, I'm not sure bariatric surgery alone is the answer. We probably need something additional.
In reference to the P-weight, I think to get the message that we should be treating those patients, hepatitis C, even although they're still maybe using drugs. My question is, how often are we getting resistant to the virus by doing this if they keep using drugs?
So the question is, if we're treating patients who use injected drugs for their hep C, are we conferring a higher risk of antiviral resistance? The answer, in the studies that have been done, the answer is basically no. So the biggest study done was by Merck, and I showed you that one, and their failure rate was low. So those the one caveat is those patients that do fail typically fail with an NS5A resistant mutation. So then you're going to be stuck treating them with salvage therapy with Vosevi.
I also have a question regarding NASH. Diabetes keeps coming up in all these studies. Now, I assume we're talking about diabetes type 2, not 1, right?
Correct.
Thank you.
Alan, just to expand on that, the VA's had a large experience, obviously, with treating hepatitis C, very successful treatment.
Yeah.
Has it been looked at all of the patients at the VA that are using drugs still, or what's the VA's sort of approach to patients that are still injecting IV drugs?
Our policy is to treat, and unfortunately, the VA has not come out with harm limitation, needle exchange programs for veterans, and that, to me, is a big problem. I think that if you're going to treat patients who inject drugs, and your ultimate goal is hep C elimination, I think you have to put in place these ancillary programs. If you don't, I think you're just, running in place.
Yeah, I would just tag on to that. As being a veteran myself, the federal government has a ways to go in a lot of areas in dealing with our veterans, not just our veterans, but our active duty force. We test people every 2 years for HIV. we refused to test them one time for Hep C. And this is an active blood donor pool. When I was downrange in Tikrit in '09, we actually had a quad amputee come in off of a mass cow, and we initiated a whole blood drive, 40 units of blood, whole blood. Later, the guy was flown out to Balad and onwards to Germany. But literally, we put an IV in a soldier and put an IV in the patient until he got dizzy. Then we moved on to the next one, and we didn't test him for Hep C. So, yeah, tackling it on the back end is one thing once they go to the VA, but tackling it on the front end is really where we should be targeting as well. And right now, the optics of that in the current administration are such that they don't want to deal with it.
Two questions. Dr. Gish, you mentioned checking for Delta with the newer medicines. Is there a difference in treatment? What's the significance of clinical results when a patient has Delta? And then for several members, patient comes in hepatitis B and hepatitis C positive. We know about the B activating. Is there a strategy about treating the B slightly before starting the C treatment? I'm wondering what the panel thinks about that.
Okay, so Delta hepatitis, the reason to test right now for Delta is it has a different prognosis, right? So if you've got a 70 to 80% fatal disease as opposed to a 20 to 25% fatal disease, you want to know that, your patient wants to know it. Number two is we have treatment for Delta, which is interferon, pegylated interferon, which none of you want to hear. And that cure rate, we don't know if sure it's a cure, we'll just talk about sustained viral suppression with interferon is 20-25%. It's not great, but it's good. There's 3 drugs entering phase 3 studies for Delta hepatitis in 2019. Lonafarnib, combination therapy, Mercludex, which is an entry inhibitor, and Replicor's drug, which is a release inhibitor. So we're going to have new drugs for Delta hepatitis, at least one, probably by 20 or 2021. Let's find those Delta patients now. Don't wait till a new drug comes out and then start looking for the Delta patients. So that's the Delta message. The Hep B, Hep C combo, it's easy. If you've got B surface antigen plus hepatitis C, my simple message is put them on a nuke for at least 5 to 6 months. And if they're core antibody positive, they don't need to be on a nuke. You just need to monitor those people with liver enzymes 1, 2, and 3 months, or if it's 8 weeks, 1 and 2 months. Then again at 3 months after stopping to look for relapse. But reactivation in core positive patients is rare, but in surface antigen positive patients, it's common.
Maybe, Paul, did you have a comment?
Just about I agree with Bob about the co-infection with HBV and HCV. Just about the Delta, Bob, you were referring to, I assume, IgG antibody positive Delta, but in the studies that are going to be done with PCR positive
That's
patients?
correct.
So that's going to really be a smaller number of patients, I assume.
So Delta positivity, we think, is 12% for total or IgG. 70% of those are replicating. So out of your S antigen positive patients, 9% will be Delta RNA positive. The number may not be quite that high. It might be 6 or 7%, but it's still high. Let's see, was it Lancet Gut, I think it was called, or Gut Lancet or something. I don't remember which journal it came out with, but there was a paper that came out. It was a global meta-analysis of Delta infection. And that paper in an impact factor journal of 17 said that we had 70 million Delta patients in the world today that are walking around undiagnosed. 70 million. I don't think the number's that high. I think it's more like 25 million, but it's a high number. And it's higher in sex workers, higher in IV drug users, higher in patients from Mongolia, Eastern, Central Asia, part of the USSR, Mediterranean. Delta's common in Africa, the Horn of Africa, and a number of countries in sub-Saharan Africa. So let's just check for Delta. This risk-based thing doesn't work.
Great. Before we run out of things to say about hepatitis C, I wanted to bring it back to what about in patients who have been treated with cirrhosis, who have been treated with DAAs and or SVR? Is your surveillance strategy the same? Do you still, Or can you back off a little bit, every 6 months, every 12 months, what's your?
Yeah, so that's a
What's your
good
approach?
question. Question is, okay, so if the risk is diminished, if your patient had F3, F4, but not decompensated cirrhosis. So first of all, if they had decompensated cirrhosis, their risk of HCC is still 2.5%, so those I'd screen every 6 months. The other ones, the risk is lower, so there's no clear-cut answer to that, but I'm sure the guidelines would say you still do it at 6-month intervals. We suck at doing that anyway. I mean, if you look at Mindy Wynn's data at Stanford on who gets screened at the right intervals for HCC, it's 20% of patients. I'm sure at Scripps it's that
25?
it's just as bad. So, we try.
Can we ask Amit about using DCP and AFPL3 in these lower risk patients?
Yeah, so a couple things. I agree with Paul that, in terms of, when you take a look at this, the incidence of HCC is decreased after you achieve SVR. The best data in terms of the persistence of that incidence rate comes out of the national VA data set, done by Fasiha, Kanwal, as well as Georgiano, that show continued HCC incidence that's somewhere around this 1% to 2%. And now tracking these patients out to about 3 to 4 years, which is the longest that we have a good number of patients, it's surprising that the HCC incidence doesn't actually drop off any further than that. And so when you take a look at these curves, simply from like the Kaplan-Meier curves, it looks like it flattens out, but now more and more data, and there's an abstract that's being hopefully accepted, I imagine, so at DDW, that will actually show this, that in terms of the numeric risk, it's still somewhere around that 1% to 2%, even 3 to 4 years later. And so right now, we know that HCC surveillance continues to be cost-effective in these post-SVR patients in F4 disease out until several years. We'll need longer data to see if it ever falls below a cost-effectiveness threshold. In terms of the F3 disease, interesting question here. So this is where EASL and AASLD differ a little bit. EASL recommends surveillance in these F3 fibrosis patients. I think the Hep C guidelines err more so on the F3. But when you take a look at the HCC guidelines from the AASLD, they do not recommend surveillance in F3 fibrosis post-SVR or pre-SVR. When you take a look at this, there's a paper that's going to be coming out in Clinical GastroHep, a cost-effectiveness analysis by Jordan Feld's group that shows that HCC surveillance does not appear to be cost-effective in F3 disease. It's our current practice that if somebody truly is F3, and I believe they're F3, meaning I don't have anything else that makes me think that the fibrosure is just off or the fibroscan's off, then we don't do HCC surveillance in that F3 group because we think the risk is low. If they're F3 and they have nodularity or there's something else that makes me concerned, then we will go ahead in that subgroup just because of misclassification. So that's the initial question. Now going on to Bob's question about some of these novel biomarkers, which I think you talk about the explosion in terms of all the new therapies coming out for treatment. It's interesting because it seems like we figured out multiple aspects of HCC simultaneously. And so similarly, we've seen some advancement in terms of surveillance tests, and this could be an hour-long talk by itself, I know, because I have...
Come back next year.
Yeah, no, exactly. But I think that, the biomarkers, AFPL3, DCP, I personally don't use them individually. I think that if we're going to use them, I find the most compelling data to be more so in this GALID format, using this as a panel. I think the data that are out there are case control, albeit large, thousands of patients in terms of case control data that shows that you can achieve sensitivities for early detection somewhere around that 60% mark. The benefit of a biomarker, you don't have to do an ultrasound, it's not it's not an extra visit, et cetera. That being said, the level of data for ultrasound-based surveillance, we have cohort studies, we have a randomized trial in Hep B. We don't have that same level of data for biomarkers alone. We don't have it for GALID. We don't have it for some of the other novel biomarkers. Our current practice is to use it in selected patients. We don't use it standard in all surveillance patients, including post-SVR. I think, not to once again give the hour-long talk here, but the reason why I think the post-SVR or the non-viral hepatitis patients are interesting is because the biomarkers may be better. You're not going to have this, false positive AFPs, et cetera. I mean, in the Early Detection Research Network study that looked at non-viral versus viral, actually, the best cutoff for AFP in a non-viral population is somewhere around 11. So it's the type of thing where these biomarkers may be very, very effective as we shift away towards a post-DAA, a NASH, an alcohol-type world.
Dr. Harrison, while we're
Let me just add on to that. Where I found GALAD to be helpful is in,
Why don't you define GALAD, because most people don't know.
he knows the details on GALAD, I don't know.
GALAD is a biomarker panel including gender, age, and 3 biomarkers. AFP, a subset of AFP called AFPL3, and DCP. So these 3 biomarkers are combined with gender and age into a semi-complicated formula. You plug these in online. Mayo has now a calculator you can do and find your actual GALAD score. Once again, go ahead, Sid.
It's like FIB4 NAFLD fibrosis score as far as its online calculator goes. You just plug in the data. Where I find it helpful, in clinical practice, I've identified one HCC in particular where the CT scan with contrast was equivocal, and the MRI didn't show rapid venous washout with arterial enhancement, but it looked like the size was getting bigger. Biopsies were inconclusive, and the lady was just following up with me, and her AFP was going up and up and up, and nothing, I would send over to transplant. They were like, well, there's nothing here. And eventually we did the GALAD, and it came back like 98% probability of HCC, and that basically forced in a laparoscopy with open biopsy that confirmed the diagnosis. So I use it, I've used it a couple times, but in that one particular case, it literally changed the management of what we were doing for this patient.
And that's why I think that using it in selected cases where you actually know how you're going to act upon these is useful. But what I have found is that if you use it in all cases, you have to know what you're going to do with that data. So for example, I had a patient who underwent an ablation for a 2-centimeter lesion, and an outside provider checked a GALAD score. And the the MRI looked beautiful, like not even like a small rim, it was like completely unenhancing. And then the AFPL3 came back at 80% for a low AFP. And so I got referred this patient, and the provider and the patient are like, I must have disease. I'm like, your MRI looks beautiful. We did a CT of the chest. We did everything. Nothing there. And this lady lost, I don't even know how many nights of sleep because of this AFPL3. And I kept trying to reassure her. We kept doing MRIs, extra early because she was afraid. And, after a year of her losing sleep, the AFPL3 came down. I have no idea why it was elevated. But it's just the type of thing where if you're going to do these biomarkers, you just have to know what your plan is when you check them. And that's why I think using them in select cases, beautiful. Until we have better data, using this in all comers, I think you may actually open up Pandora's box and you can't put it back.
Yes, I just wanted to clarify what we do with a positive Delta antibody. It suggests to me that, just hearing the statistics was enlightening to me. It's like almost one of maybe 8% of our patients are going to have a positive Delta. My understanding was that just generally treating the underlying hepatitis B would inactivate the virus. So I'm just wondering if we effectively treat hepatitis B, why do we still need to know what the Delta is? And I guess that's what I'm just trying to clarify in my mind.
So the first thing we have to realize is that nukes have no effect on Delta replication. Delta is an RNA virus that's related to a plant virus, jumped into humans who knows how many thousand years ago. It follows hepatitis B around the world in many locations. You suppress hepatitis B, you have no effect on Delta replication. In fact, Delta suppresses hepatitis B replication on its own. It basically hijacks a lot of the replication machinery. So nukes, TDF, TAF, and Entecavir, no effect on Delta, and it will go on replicating this high risk. So you need to find out who's got Delta antibody, who's RNA positive through ARUP request soon, and then you need to do surveillance for progressive liver disease at close intervals, and then think about interferon or think about new clinical trials. There's a large phase 3 trial from IGER that's starting in the US this month, and there are centers around the US that can include patients in that Delta trial. We want to get to Delta cure with these new drugs. That's still going to be a few years out, but hopefully that answers your question.
Patrick.
they're delta RNA positive, extremely high risk for progressive disease, even with normal enzymes. I would be monitoring them with imaging, including transient elastography.
Let me make a comment about liver enzymes. So as a hepatologist, I feel like we need to be like on the bandwagon, going around the country saying, don't just look at the liver enzymes. Like, they don't really tell you the story. In fatty liver, 50% of people have completely normal ALT and have progressive liver disease. It is a poor indicator of underlying liver disease. And I'm sure it's the same for viral hepatitis as well. It's something we look at, and I get concerned more about the ratio of ALT to AST than I do about a number. But please don't just look at the ALT.
Patrick, I wanted to bring you back into this a little bit because I'm sorry, can I come back to you in just one sec?
Yeah, sure.
Okay. I wanted to bring you back into this because the TEG is obviously a very good way to assess plot formation, stability, and resolution. And many of us now have it, as you explained, but how do you, in real life, interpret it? Do you go to a website and look at it looks like a lunar orbit diagram when you look at it. How do you use what you see on the TEG printout to guide your therapy and where you intervene?
Yeah, there's a little bit of alchemy and interpretation of TEG curves, and the experienced anesthesiologists that have been using them for a long time they can look at them and tell you exactly what's needed. I challenge that frequently. I think we're still determining what the right criteria are. Luckily now, especially with ROTEM, you get a number. You get a number for an R time, you get a maximum amplitude, and we're starting to see in the literature now some numbers that are at least a reference point that we can start looking. So a delay in clot formation of more than 45 seconds, excuse me, on a ROTEM is a sign of delayed or poor clot function. A decreased maximum amplitude. If you go back and look at the original Starzl papers using TEG, there's very beautiful curves for the various phases in the operating room for an hepatic phase, and this sort of display of what's happening within the coagulation system in the profound changes of transplant. For pre and post procedures, we're not quite sure. I mean, I think we're still exploring that. We need good numbers. Todd Stravitz has shown no change whatsoever in TEG with acute liver failure, which is one of the most striking diseases with a super high INR. So I don't think we know. I think with ROTEM, we're using markers of platelet function, we're using delay and then decrease in maximum amplitude, and there's some in the literature out there.
Yeah, it's always fun to watch the hematologist run to the computer to look at the diagrams.
Right. No, you can measure it out. The ROTEMs will spit out a number now. You actually get a number of the various parameters, and those numbers are somewhat helpful, I think. We're still determining how helpful, though.
You have a comment?
Patrick, I'd invite you, I can send you an algorithm we created in Arizona, Stanford, and Reno that actually gives you exactly what to do for different numbers. It's based on experience and on trials. It's also on my website, so if you just look at robertgish.com, you can take a look at this protocol.
Add that to the.
And they're out there. You can find them for sure.
Do you need to?
By the way, there's going to be a lot of upset radiologists Monday morning in Southern California.
Oh, the radiologists, I was just speaking with one. They're actually happy to not transfuse patients because it's a pain in their neck too. And if it doesn't change bleeding rates and things like that, they're actually will be on our side. I find the anesthesiologists very sympathetic to our cause as well.
And the blood bank.
And for sure, blood bank.
I'm sorry, your question?
This question is for Dr. Harrison. So for NASH patients, have you ever used the combination of P-glycosone and vitamin E together? And if so, is there any difference in terms of dosing?
Yeah, you can use both together. In fact, it's frequently done. I often see patients that are sent to me on, 30, 45 milligrams of PO with 800 of vitamin E. Again, the data, there's no study looking at combo therapy with that, but there's nothing that says that you're putting the patient at increased risk by doing that from a non-alcoholic steatohepatitis efficacy perspective. You just have to quote the risk of both of those individual drugs to your patient. So you know, I've seen endocrinologists send me patients where they're on 45 of PO, they give them 20 of Lasix once a week, just to manage the edema that's coming in with the PO. And they talk to them about 800 IUs of naturally occurring RR alpha tocopherol, and they send them to me just for a second opinion. And they're doing well, the liver enzymes have normalized, their FibroScan is a KPA under 6. I can't put them in a clinical trial, even if I took them off those medicines or they were on stable doses for more than 3 months. So, I mean, there is individual patients where I think that could be an option for you.
Thank you.
Francisco, you a busy liver transplant center. And
A question for Dr. Harrison. Should endocrinologists be screening for fatty liver?
Oh, that's the easiest answer of the day, absolutely.
I've been telling them, but they
Using
don't.
what?
So-
Using FibroScan or using?
Ultrasound, just an ultrasound?
No, I would use FibroScan, and I would combine it with the AST that I presented earlier.
So FibroScan and AST.
FibroScan and an AST, just keep it simple, fast. FibroScan, AST. The interesting thing is we presented we'll be presenting some data at NASH-TAG in January and also submitted to EASL. We went out and did FibroScans in 500 patients that were endocrinology-based and 500 that were in GI clinics. And we looked at all the demographics, and we were trying to draw some conclusions about the severity of underlying liver disease. And one of the most striking things I found, and this blew me away, endocrinologists check LFTs in 94% of their patients. GI docs, 34%. It's all about the scope, right? But, I mean, at the end of the day, the endocrinologists are checking because they're adding statins and we're doing things, and they know to look at numbers. And I'm not sure why only a third of the GI, but I see that over and over again, even among colleagues that refer me patients where I'm looking to put them in a clinical trial where the AST has to be greater than 20. I don't want to just screen them without an LFT. The majority of my patients don't have a set of liver enzymes from my GI colleagues for me to go historically and look and see. They say they have fatty liver, refer them over to me for treatment. So, absolutely.
And another one is, why do patients that lose weight with bariatric surgery, they have much more improvement in their liver biopsy than the ones that lose weight without bariatric surgery?
Well, I think, bariatric surgery is very prescriptive, right? To get to bariatric surgery, you have to basically show that despite extreme close follow-up, you're not losing weight, you're not achieving, where you need to go. You have to show you're very compliant. You have to show lots of things. Like you can't just jump into a bariatric surgery procedure, at least in Texas. There's like a 6-month, process you go through. And so I think we're basically selecting patients that are highly motivated and that are very likely to do the things we want them to do, that would probably potentially be obtainable with the same aggressive management if they didn't go through bariatric surgery. Unfortunately, once they go down that road, they're committed to that procedure often, and they do well. There is data now, however, coming out that within 5 years, they're back on a PPI, and they also end up gaining, a significant amount of their weight back as well, so.
Dr. Harrison, any implications when your fatty liver patient comes back, low-grade, anti-smooth muscle antibody positive? Do these patients have a different disease? Are you treating them differently? Any long-term implications?
So that's a third of our patients will have ANA and ASMA positivity up to 1 to 320. And there's really good data to suggest all you're dealing with is a NASH patient. In fact, Beth Brunt was on a podium, asked that question, and she's like, if you're seeing coexistent autoimmune hepatitis in the setting of NASH, you're going to usually see other things. Histopathologically, you'll see a lymphoplasmacytic infiltrate with interface hepatitis. You'll see rosetting. Biochemically, you should see an elevated total protein to albumin ratio, often because it's a lot of circulating immunoglobulins, so the total protein will be high and the albumin will be low, typically in that setting. But it doesn't, again, autoimmune hepatitis is not just a one-and-done diagnosis. There's lots of things.
So those patients will behave in a similar fashion to you?
Exactly,
To you, non?
What about on the biopsy? If you biopsy these people with, let's say, an ANA of 320?
Yeah, so usually all you see is NASH. If the only thing that gets me fired up about autoimmune hepatitis, marker negative or marker positive, is a lymphoplasmacytic infiltrate with interface hepatitis. If I see that, I'm really seriously thinking there's a coexistent liver disease going on.
And you can look at the total globulins also, Sam, and everybody. If you have this high ANA, which 1/320 is not very high, the total globulins are normal, they're not going to have autoimmune liver disease. It's at least very unlikely.
Yeah, the other thing you can measure is just an SPEP. So in my clinical practice, I just get an SPEP because the SPEP tells me the IgG. It tells me if I'm, essentially if I need to worry about alpha-1 antitrypsin deficiency. It gives me a good amount of information that's helpful.
Can I ask Ahmed, I want to ask you a quick question about, we don't biopsy HCCs by and large, at least at our center, I'm sure most places. However, you've now got 6, you just showed us 6 drugs that are newly approved for second-line therapy. You've got PD-1s, PD-L1s, which are often guided, at least in other cancers, by mutational analysis, et cetera. So should we start considering biopsying these patients, or what's your view?
So unfortunately, there hasn't been any biomarker that's actually guided therapy, even with the PD-1s. So when they've looked at, for example, PD-L1 status, at least in HCC, does not actually correlate with PD-1 response. So we currently have nothing that actually tells us who those 15 to 20% of responders with PD-1 inhibitor therapy is going to be. So a couple things that have borne out. So MSI high has been shown to be correlated with PD-1 response in other tumors, but accounts for about 1% or less of HCCs. And then mutational burden. But the mutational burden right now, those data are really early in terms of HCC, and once again, it doesn't look like that's a large proportion of HCCs. So I will say that in terms of clinical practice, I don't think we currently have anything that actually that says that we should start biopsying. And so there was data actually coming out of Sloan Kettering that actually did next generation sequencing on all these tumors, and they found very few actionable mutations in terms of HCC that guided therapy. The second thing, though I think your point is well taken, that we probably have taken a decade to start having advances because we don't understand the tumor. And so really where I think that we need to start biopsying is research protocols in high volume centers so we can actually do research and so we can become smarter, but not in routine clinical practice.
So, Al?
I was going to ask Dr. Harrison a question. Can I?
Yes.
Okay. So Dr. Harrison, how important is it to differentiate NASH from bland steatosis? How do we act upon the two? And to supplement that question, how often do we see NASH without a significant fibrosis, your 8.5? And when do we biopsy, basically?
Wow.
You got 30 seconds. Another hour.
Oh, my goodness. Okay, so there is a huge difference in NASH versus isolated steatosis. The only caveat to that is if you have steatosis with some inflammation, Newcastle has shown that about 40% of those people actually have NASH. You just missed the ballooned hepatocyte. So I would take that with a grain of salt. However, here's the deal. We need to identify patients that are at risk for NASH because they do progress down a very slippery slope and can do so at the rate of 1-stage progression every 7 years on average. Now, there's high variability to that. This is one area where high ALT comes into play. If you have a high ALT, and nobody's defined that number, my guess is over 100, and you have diabetes and obesity, that's a population that rapidly progresses, much quicker than 1 stage every 7 years. So it is, now how do we get at that population? That's exactly what I think we've been able to define some left and right boundaries around, and that is a cap of 300, actually theoretically a cap of 280 correlates to a PDFF of 5%, which is the minimum you need for fatty liver. For clinical trial development, I bump it up to 300 to try to get a PDFF closer to 10%. However, for the purposes of just finding a NASH patient, A cap of 280 with a KPA of 8.5 and an AST of 20 will define the population you need to worry about. If it's less than that in any one of those parameters, well, if it's less than that in KPA or AST, I wouldn't worry. What we find often with advanced liver disease, the so-called cryptogenic cirrhosis, is a normal cap, 150, 200, but a KPA of 25 or something like that. And that's, that's a little bit of a tougher animal to find. In San Antonio, the biggest thing I can tell you about FibroScan that please don't do is don't get a KPA of 9 and try to box it into a fibrosis score. Don't say this is consistent with F2 disease, because it's not. In the U.S., morbid obesity and visceral subcutaneous fat actually falsely elevates the KPA score because you begin to measure at 25 millimeters. That 50 hertz shear wave measurement begins at 25 millimeters. So if you have 25 millimeters of subcutaneous fat, you begin your measurement in subcutaneous fat, and that falsely elevates the KPA. I don't know how many people I biopsied with KPAs of 17, and they have really minimal to no disease. So what I tell people is the negative predictive value of that scan is highly, highly effective. If they're less than 6, I don't worry about it. If it's 6 to 8.5, lifestyle modification. Greater than 8.5 with a high AST, they need something else done. So what I tell people is a positive FibroScan doesn't tell me the definition of your disease or the severity of it. It just tells me we need to do more workup. So I didn't answer all your questions, but I didn't have enough time.
I have one last question, Bob. Many of the people here attending are consulting gastroenterologists, and when they get called by rheumatology or dermatology, their patients are going to be put on biologics, and they're core antibody positive. What do you tell them? Do you recommend suppression or monitoring, or what's your approach?
The simple answer is look it up. Go to the AGA guidelines and technical review that I helped write with Bob Perillo, Ingvi Slater-Flack, and then Raj Reddy did the ultimate review. And look at the drug and look at what drug combination they're on and go to low, moderate, or high. It's pretty simple. You got a TNF inhibitor, they're on steroids, a TNF inhibitor, they're on another drug. They're probably moderate risk and either need a nuke or need close monitoring. The final comment is that 7% of core positive only patients are replicating. They have OBI, occult hepatitis B infection. So if you've got a core only patient and their ALT is elevated, you need to check an HBV DNA.
Great, thank you. Well, with that, I think we need to adjourn. We encourage all of you to attend the